looking at the anatomy, that it looks like pretty usual anatomy for transposition of the great arteries. So you see basically the aorta anterior, pulmonary artery posterior, and left and circ coming off the sinus 1 and the right coming off sinus 2. Doesn't look like there's obstruction in the outflow tracts. So when you divide, you obviously want to leave enough room to the coronary sinus to get decent sized buttons. You can later shorten it. So, but the way I usually start is at the spot where I put my plegia tack in, nick the aorta, and then look inside if I'm distant enough from the coronary arteries and the valve, and then divide it. And this is relatively high compared to the TGA. And then you can place some retention stitches there to keep your aorta in position. But the trick is then you're harvesting your coronary artery buttons, and you first of all inspect where your coronaries are. You can probe them to see where they run and to get a better understanding of the more peripheral anatomy. And then you're harvesting your coronary buttons by incising the aorta. And then you start more or less right above the commissure. So I usually start with the right coronary button. You start aiming towards your commissure so that you're ending up right above your commissure. And then you want to leave a decent rim around both of your coronary ostia. And the way I've been taught this is that you kind of turn the tip of your spring scissors towards the post. So you're trying to really get close to your valve. And what's a little bit different here on the model compared to real life is that the valve cusps tend to fall into the sinus, so as if the valve opens up, and you have to either ask your assistant to push the cusp away. So sometimes you can feed in the tip of your forceps and keep the cusp expanded, just to make sure that first of all you're seeing the nadir of your cusp well, and also that you're not accidentally cutting into your cusp. And as you're approaching basically the bottom of it, you're feeding the tip of your spring scissors into basically the space just next to the aorta. So you're not dividing everything because you would potentially be at risk of dividing the coronary artery accidentally or branch thereof. And therefore, you're kind of really just getting right into that space of the aorta and the adventitial tissue around it. And then at some point you'll have to stop and approach it from the other side. So at the top, it's again not very crucial where you start. And then you're aiming towards your post again. Once you're getting into the sinus area, you're again feeding that tip here into that space, and try to stay thereby away from the bottom. So you see I'm kind of leaving here a little bit of tissue there, same here. That's really just to make sure that you're not accidentally cutting into a coronary branch. Much easier once the aorta is divided, you usually get some extra mobility there. And then the rest is usually divided with cautery. So you can go through here and mobilize the whole button. Usually very low cautery setting. Sorry if I moved away. To again avoid any damage to it. And then you can always control where your coronary is running. It may not be as obvious here. It's not blood filled, so sometimes difficult to see. And if you're in doubt, you just feed a probe in and pass it along to understand how far off are you. And then the trick is to mobilize it without mobilizing it too much. If you do that too aggressively, you're ending up with a long unsupported segment of coronary artery. So I'm doing this with the scissors, but I would do that all with cautery here. And if you have a long unsupported segment of coronary artery, it tends to kink easier once you're reimplanting it. So you want the segment to be mobile. You can work on that later further if you kind of see where it's going to end. You may want to free it up further, but that's certainly reasonable distance there. And then other coronary button again. They usually leave a strip here. It's not that important that there is a lot of aortic tissue at the top here. It's really, you just want a proper commissural post there that you can later use to reconstruct your pulmonary artery. And so same story here. Again, if you're wondering where things are, use a probe and kind of follow the course. Be careful. I've seen people perforating that with the probe, so it's thin little arteries there, but usually not very difficult to assess the course. It's just don't cut it if you don't know what you're cutting, so don't damage the coronaries. That's obviously a big deal then. So again, I mobilize it here with scissors, but I wouldn't do that in real life. In real life I would just buzz that away. And then you're dividing your duct and work on the branch PAs there. So usually, again, double ligation cut in between. That can go out of your way. That's over sewn. And then you free up your branch PAs. There's a lot of adventitial tissue. Very satisfying to clear all of this off and see the branch PAs move around. And then you can also incise your main PA. And when you start dividing your main PA, you have to keep in mind what you're going to end up with, because that's going to affect where you're going to reimplant and how straightforward the reimplantation of your coronary is going to be. So you want to be as high as possible to leave as much of a root to reimplant it. I'll get to that later again. But you also don't want to be too close to your branch PAs. It's very easy to cut in accidentally into the orifice of the right. Usually leaves a bit earlier. So what you're doing is, again, a little incision in the front so that you can peek inside, and then you're dividing it, and you're aiming to just not cut into your right pulmonary artery. If you do that, then you're not going to compromise your PA, your branch PAs, while leaving the most root you can get for the reimplantation. And the main reason for that is going to come later. You usually have your cross clamp in like this, yeah. And at this stage, once you're really happy with how well your branch PAs are mobilized, so you usually want it to be past the early branching in the hilum, so beyond the first takeoffs, and really careful to divide every adventitial tissue. Then you want to feed it basically in front of the pulmonary artery. So that's the LeConte maneuver. Usually you ask the assistant to lift it up, and then you can probably do that right now. Just lift it up, and then adjust the PAs. Then you're grabbing it with your forceps. Make sure you have a good grip, that you're not accidentally losing it. And then you replace the cross clamp so it kind of holds back your branch PAs in front of the aorta. And then as the aorta shifts posterior, you're also changing the anatomy of your aortic arch a bit, and that's where you can, usually not as aggressive as you might think you have to, but you can shorten the aorta a little bit to account for, the lesser, the more angle turn that the aorta takes at the time. So a few things are actually easier in real life than on the model. Also, if you have a good assistant that warns you that you're doing something stupid.
Do you have any tip that how your line 3 o'clock to 3 o'clock and 9 o'clock to 9 o'clock?
Yeah, I'm usually going, it's not exactly 3 o'clock, but it's probably somewhere around 2 o'clock or so, where I start anastomosing that. And then I think another key aspect is usually there's quite a discrepancy between the blood vessels. So you may actually want to account for that. And when you start tailoring, it's always nice to distribute it equally, the tailoring, but on the other hand, the suture line that you're suturing right now is the one that you're getting to. Probably it's going to be the most difficult to get to later, because it's all the way at the back, so you probably don't want to take much differently spaced bites in that suture line, and rather use the front or the sides to account for differences in size between the arteries. So I'm trying to speed that up. It usually takes smaller bites, also because I'm not wearing loops. If you can do that without loops, probably speaks about your aging. I can still see it good. Okay. Barely seeing it, and I have to look around the camera. It's right in my way. No, just leave it. The camera is good, I think. It's pretty good. It's just exactly the view I want. So the other thing that you have to do before you complete, or probably even before you start that anastomosis, is to mark your commissure, because once your anastomosis is closed, you won't be able to tell where your commissure is. With a little silk suture, you're kind of looking inside your root, and most of the time you just need the anterior commissure, but here the commissures are not aligned. Yeah, they are aligned. But yeah, but you're kind of marking at least the one that you're likely to come the closest in contact with. And what I do is basically, it's not a transmural stitch, it's really just like a little catching the blood vessel there, that sits right at the level of the tip of the commissure of the respective one. So that you not only get the position of the commissure itself, you also get to know kind of if you're above that level of the commissure, you're away from the valve in total, you're above that. And below is where your sinuses start, and where your valve is. And I think here it's smart to put two on, because the other one sits where you're probably gonna get into conflict. Yeah, here I see the commissure on the outside on the model, but what I usually do is poke in from the outside, look inside, and see where kind of the tip of my
In a real story,
needle comes in.
Real story, do you see that, or that is not possible?
You don't really see it from the outside. So I'm just
No, it's
leaving
not
that.
very obvious from the outside.
I've shown the basic concept, I think. So it's not obvious from the outside, so that's why you have to mark it before. And then if you use the time, you can also test where your coronary is likely gonna sit, and therefore change the way you're anastomosing the aorta together. So still inside, but I'm just gonna I might get away without doing that in general here, but just for teaching purposes, maybe wise to do that. So you're stopping way before you're done with the commissure itself. Complete the other side, and then the gap that you're leaving in between is filled with a separate running stitch, and I'll get to the reasons for that in a second. Okay. I'm not sure where this is likely gonna end, somewhere there. And that's a bit of judgment. There's nothing wrong with having to adjust these stitches afterwards. It's more to prepare yourself in case the coronary buttons have to cross your neo-aortic suture line. So you're basically starting off just as if you'd continue your previous suture, but leaving a little gap so that you're not going to cut your suture line later. Call this a day here. So, all right, so you can leave that. And put it all together. This goes here. And now you have two potential areas where you can cross your suture line without actually cutting your suture. Next thing is to implant your coronaries. So one thing is to find the spot where you want to implant them. So one idea is to take your cross clamp off at the time, and obviously de-air, but you're taking it off to allow the root to fill and become distended, so that you judge basically the implantation site in an anatomy that it's going to be like afterwards. And the crucial thing at the time is also to allow your heart, it's usually pulled back a bit for exposure, to come up again. And you have to find a position of where the heart's likely going to sit once everything's reconstructed. Otherwise, if you keep it pulled down, you may misjudge where the corners end up lying. And then you probably have to free up that coronary a bit further. But you're basically turning the button posterior towards the neo-aortic root, So just let it come up a bit and see where in the coronary sinus it would sit. It would likely want to sit in here. And I'm judging basically always the position of this corner of your coronary. So the one that is the furthest left and the lowest point of the coronary button insertion. And there you see it would sit very close or even below the actual commissure. And then you're taking a knife and just marking that spot here. The nice thing about having the cross clamp off at the time is also that it pushes the valve down, so you're not at risk of, even if you're a little bit in the sinus, of cutting into your coronary. It's really just a little incision there, just to make a hole. And the same is on the other side. I usually mark these with a pen before to just make sure that, once you put the hole in, somebody needs to close the hole. There's a little bit of blood going around, so you don't want to spend a lot of time judging again where it all might end up. And then I'm going to do the same on the other side.
You use the pen?
That's okay. For the sake of the model, it's fine. So a little incision, just make sure that you find the hole again. And then you can reapply your cross clamp and then make your trapdoor. And the trapdoor is a medially based trapdoor. So it was there. So you're cutting in like this, probably a bit big, and cutting over like this, so that you have this little flap going in like this. And the idea is, if you imagine how your trapdoor opens up and how it kind of aligns your coronary button, if it's medially based, you're reducing the amount of turn that the coronary has to take to reach your neo-aorta. So if you, just for the opposite, if you've done a lateral opening or a lateral base of the trapdoor, you would have to turn it even further posterior to reach that trapdoor. So it's sometimes easier if you paint that on a piece of paper to explain, but it reduces the amount of torsion that you have to put on your coronary. There you're probably about the time where I give a second dose of bleach or so. And then I'll start at that point here that I mentioned before. That is kind of the lowest and furthest leftward one. And start suturing. And it's a typical example of how your body position helps you suturing all of that. So because I usually turn the left shoulder in and suture it kind of from the head of the patient. And then it's really just a running suture. It's fairly simple. Just make sure you're not rushing it. You want that preferably to be not bleeding from this area. These are very tricky bleeders to fix. It's all kind of hidden from the pulmonary artery that sits on top later, then that it's kind of the underside of your button. It's all a bit inconvenient. I mean, you can't fix it, but much easier if you don't have to. Then once you're reaching over here, you can start doing single-binded stitches. Always keep in mind where your ostium is. Here you can obviously see where it's going in, but without the different color, it's sometimes better to double check. You may remember from when you resected it, when you harvested the button, where your orifice lies. It's not always central, so you may have part of the button that is a bit closer to the coronary and others where it's further away. It's also a time where you could adjust the button, cut it shorter. Right. And not sure what the other piece is here. Oh, yeah. Deep spite. And same on the other side, and just speed up that a little bit. Cut this a bit shorter. There you see that it ends up being lower than the actual anastomosis, and so the longer your root is, the more likely you're staying below. Not sure at the moment, it's a bit pulled down. This angle may become worse at the time when we're releasing the heart a bit. I'm just gonna tie this up. It's not gonna bleed for sure. Alright. And then you'll do the same with the other side. So you can relax that a little bit and see. Doesn't look too bad. Actually, with the course, doesn't look like it's kinked there. And then the same here. Tricky thing is to find your previous incision again, which was somewhere there. Kind of a bit close to each other there. And another signal. And if you're hitting just the post at that, sometimes where your coronary wants to sit is where the post is, so you have to kind of become a bit in have to figure out where best to seat it instead. Then for the right, I think David can correct me if he thinks differently. Many times easier to go further posterior and higher. Same thing here. pull back the tip of the button. Maybe. Come down a bit. All right, and then elevate the button there with another hand. Just take this and don't follow. I think for the model it's easier. Usually had a stay suture in this one to just keep it out of my way. Just grab the posterior. So it's really same principle on how to suture this button in. I'm going to come down a bit. Usually don't want to have them too close together so that the neopulmonary arteries then kind of riding on top of them. But I think here the actual orifices are reasonably distant to each other. Just going to quickly finish up here. Don't judge me by these last two stitches. I just want to get it done here. Okay. And then you obviously want to de-air. You can use your previous suture line to de-air, but I usually have an LV vent in to because de-airing in the switch once the PA's in front and everything is a bit tricky. You don't want to have air going to your coronaries, and you'd be wondering whether it's air or it was you. Okay, so I'm not going to tie this now, but you're taking the cross clamp off, and then I think the best judge is how nice your heart looks when it's getting reperfused. So if it starts returning to regular normal rhythm and is beating happily, even just looking at it from without echo tells you already that you should have done well. And then reconstructing the pulmonary artery I don't know if David's going to show that later, but for time's sake, I'm going to skip that. But it's a nice time where the heart is reperfusing already, gaining some strength. And then what we do afterwards is basically checking with ultrasound if there is a normal flow pattern on the coronaries. We usually don't want that gradient to be more than 80 millimeters mercury, which is a very, it's a tough bar. I think not every center would usually look after that, but that is a good indicator that you got it right and that it they're re-implanted in a correct position. All right, I think that's it.